Fibromyalgia Friends together, and I also sit on the British Pain Society on the Patient Voice Committee, as long as also doing a number of other national and local roles. And Fibromyalgia Friends Together is affiliated to Fibromyalgia UK, that Des is the chair of. We'll tell you more about both of those groups later on in the session. And of course, just to say that this is part of our free Footsteps festival program. It's a year long and possibly will go on longer than that festival, where experts, people with lived experience, talk about pain in its many different forms and kind of real positive ways in which to address it. Also gives information on how to access support and where to go to. So welcome to this session. So I will hand over to Des, who will tell you more about himself and his organisation. Des.
Thank you, Mark, and it's a pleasure for me to be here as well. As Mark said, I am chair of Fibromyalgia Action UK, and our charity is the national charity that looks after or tries to raise awareness for the condition across the whole of the UK. And we're a very small team that run and a very small charity, but I'll tell you what, I'll get the slides up now so you can see something as well, if that's okay. I'll share the screen so I can at least get this technical thing out of the way. And hopefully you'll see my screen in a second. Now, for me personally, I've had fibromyalgia for about 15 years, maybe a little bit longer, and got involved with the charity, initially doing their website, and then gradually, because I was acting as a trustee and doing things like a trustee, the trustees decided to adopt me, and now I'm the chair of the charity. The charity, as I said, is quite small, but our whole point, our whole purpose is to raise awareness of this condition. And let me just start the slides. What I want to talk about is about the condition, and then a little bit about the charity and some of the activities that we take part in and some of the people that we've helped or are involved. But first of all, fibromyalgia, what is it? If you've got it, you probably are already very well acquainted with it, but it's always described or normally described as a pain condition, but it's more than just a pain condition. But it's pain is not just something that you'll get in your arm or your leg. It's a widespread pain condition. And what we mean by this is you'll have it all over your body. And it's always described or often described as chronic pain. And chronic doesn't mean severity. Chronic means a length of time. Typically 3 to 6 months is what you would be expected to have pain for. But we get the added bonus of having fatigue and exhaustion, non-refreshing sleep. And it's a little bit of a cycle whereby that if you don't get the proper amount of sleep, then you'll find that you can't deal with the pain properly. And if you're not able to deal with the pain when you're lying in bed, then your sleep is going to be interrupted as well. So chicken and egg to an extent, but then we have cognitive disturbances, confusion, or as we call it within the community, fibro fog or brain fog. And this can be, sometimes I give it a live example while I'm doing this chat, I probably will do again, but it could be you're forgetting your words, or as I often describe it, the word is right in front of you, but you can't quite get it, and you'll perhaps have a similar word. So could you pull out that chair, and you'll actually say table rather than chair. It's something that's often related to it, and it's very frustrating. These are the core symptoms of fibromyalgia, but there's other things that are part of it, comorbid conditions, and other symptoms that come into it. But if you don't have these present as a core symptom of fibro, then it's worthwhile talking to your doctor. And to be honest, it's actually worthwhile talking to your doctor when you're diagnosed and making sure if any new symptom comes up that you get it checked out to make sure that it's not some other similar condition, because If anybody that's been diagnosed with fibromyalgia, you know that it's a long journey. The average within the UK is 3 years, but it's not unusual to find someone taking 10 years and many doctor visits, many hospital visits before they're diagnosed, and a lot of other things being ruled out. People that suffer with this condition, yeah, it's a huge impact that it will have on you. It steals from you, takes away choices, it changes you to a certain degree. You have to come out the other end and actually accept it and feel that you get to perhaps a place where you can understand where you're at and then continue on. But the simplest of tasks are sometimes very difficult to accomplish. Who and why? First of all, the who's affected by this condition. Now, we use the figure of 1 in 20, and that's based off of if you go to fmeuk.org/prevalence, you'll see the survey that we based that figure off of. It's also what NHS Choices use, because when they did a multi-country survey across Europe, they found that the range of people affected by this condition was 2.9% to 4.7%, which gets us the upper range towards that 1 in 20. But the way that the NHS keeps records on conditions, and particularly musculoskeletal conditions, yeah, we could be in a much better position about knowing how many people are affected by this condition if they kept better records. And it's unknown why it does this, but it impacts more women than men. The ratio, we've got it as 7 to 1 there. Not so long ago, it was 9 to 1. The criteria for fibromyalgia, everybody, if you talk to anybody that talks about diagnostic criteria, you'll probably hear the words ACR, which is the American College of Rheumatology. It used to be the 1990 criteria that used tender points to test whether you had the condition. They have fallen out of favor, and we now use the 2010, or if you're keeping up with these sort of things, the revised or the modified 2016 criteria. And why is that important when we're talking about men and women? It's because when that criteria changed, one of the reasons it did change is because people were perhaps getting 10 of the 18 tender points or 9 of the 18 tender points, and they were just below the threshold of the 11 that would have qualified them for fibromyalgia. And often men were perhaps being ruled out of this because our physiology is slightly different, musculature. So there was a suspicion that men had everything, all the parts of fibromyalgia, but they weren't being diagnosed. Now we've seen that change. The amount of young people being diagnosed, the amount of males being diagnosed. It used to be that we had a stereotype of a 40-year-old plus woman that would be the typical person that would be diagnosed with the condition. And we do think people were presenting with fibromyalgia symptoms, would get the diagnosis if they were in that description, but weren't being diagnosed if they were outside of it. And plenty of examples of people not getting the label because they were, let's say, 15-year-olds and doing their hires or doing their A-levels. And yeah, you're too young to have fibromyalgia, so they weren't getting the proper treatment or the proper attention. Now, why do we get this condition? What causes it? Now, before the discussion, we were talking about genetics, about how it plays a role within fibromyalgia. I think it was the early 2000s that the research started to crystallize around about this. And they found that there was some genetic link. They're still not quite sure what it is, but think about it as a risk factor, that it might pass through the family line, but there's no guarantee that you're going to get this condition. But a trauma may occur, and that could be a car crash. It could be giving birth. It could be some sort of a virus that causes your immune system to overreact. You could have an operation, or it could be emotional trauma. Now, the thought is that you have one of these traumas through your life and you're already predisposed towards having fibromyalgia. And then, yes, you end up getting the symptoms and being diagnosed. But down the bottom there is unknown. And I put my hand up for this one because I don't have any significant trauma that I can identify. And there are plenty of people within the community that can't identify when a trauma occurred or what might have triggered it or any underlying reason that they might have actually had fibromyalgia. There's a lot more to be found out about why we get fibromyalgia. And I say the journey, and I really do mean that when you get diagnosed, that in itself is a journey towards getting the label of fibromyalgia. But once you're diagnosed, what then happens next? It's hard to be diagnosed because it's such a complex condition. There is a lot of other conditions. Arthritis, we go to rheumatologists a lot of the time, and that's because a lot of the conditions that we perhaps get confused with are in the scope of rheumatologists, autoimmune conditions. That's what they look after, and fibromyalgia mimics a lot of them. So we have this overlap. They have to rule these out. And that's why you have blood tests that come back normal. It's frustrating, but they find out that you don't have raised inflammation markers, and then they rule out other conditions. And some people say it's a diagnosis of exclusion, but we get this label perhaps after several years, several doctors. It's always frustrating, but it's a journey to get the diagnosis. And then what can we do with it? How can it be treated? First of all, there's no cure. Doesn't mean there's no hope. There is research that was just actually released or published this week from PacFind, and they were talking about people being diagnosed and how it's useful to be diagnosed. So there is a benefit because you know what the condition is. You're not then worrying about what else it might be. I know when I was diagnosed, I had the thought, is this cancer or is this MS? And probably a lot of other things that I was thinking about. So when the GP said to me, it's fibromyalgia, it's lifelong, you're going to have it forever, but here's what you can do. And then he gave me, and this sticks with me all the time, that your knee might be hurting normally, and in someone that's healthy, that pain that you have in your knee is your knee telling you, yeah, take it easy, don't put as much weight on it, so you don't make more damage happen, and you don't cause yourself more pain. But with fibromyalgia, it's actually your central nervous system that's sending false signals, that's overactive, that then has this feedback coming back to you. So if you want to move about and your knee's hurting, then yeah, you can do. And that stuck with me, and it's behind a lot of the my own self-management regime. But treatment is focused on managing the symptoms, dealing with the pain. We now have NICE guidance on chronic primary pain that fibromyalgia features in, and some of the options that I'm talking about here have actually been taken off the table by, in NICE's opinion. It doesn't necessarily mean that they don't apply. It used to be that it would be a recommendation of a combination of painkillers, antidepressants. Amitriptyline is normally the first thing that people will be prescribed, and then anti-epileptic drugs like gabapentin and pregabalin. And these are useful for a lot of people. And a good treatment plan can make people get back to work, can allow people to do more exercise to keep active, because activity, just skipping ahead, if you do simple, gradual and gentle exercises that you increase over time, it can be very beneficial. There is good research for that. But again, if I go back to my knee, sometimes you'll feel pain. Sometimes it'll be the right thing to work through that pain. But you've got to listen to your body, not overdo it, and finding the right activity to take when you have fibromyalgia can be very helpful. So something like Tai Chi or yoga, especially ones that you can do while you're sitting down, they're very useful because it's gentle exercise. It's also brilliant if you can find somebody that actually knows what fibromyalgia is, so they can understand that you have to take a break or why you have to do it seated. But they also have a meditative aspect, a mindfulness aspect about relaxing you, because stress isn't our friend. And to go back to the one before, cognitive behavioral therapy and counseling, a lot of people are resistant to this because it automatically applies in people's minds that, you're saying fibromyalgia, it's all in my head. CBT doesn't necessarily affect the amount of pain that you're experiencing. but it can affect how you deal with it, the behaviors that you have, the way that you approach the world, and that sometimes you can modify your behavior. You still get the same pain, but you're able to do more. Now that's a better place to be, that you can actually have a more enjoyable life while the pain is still at the same level. It's not a win on pain terms, but it's a win on the basis of your life is more like what it used to be and you're doing more. So some of these techniques are worthwhile to consider. Sometimes they have to be at the right time in your journey. And that journey, unfortunately, we don't have a map. Everybody's journey is different, and there's a lot of dead ends. And we find those dead ends every time we go to a doctor, every time we have a consultation. And sometimes we have to go back a little bit and try that dead end again. And then you find out, no, there's a way through here and I can do it. So it's complicated, and your journey and my journey will be different. So finding people that can help, finding a support group, Mark's support group, for example, will be essential to people that go to it. You'll find, and I actually should have asked Mark about this, and he'll maybe nod his head to this, but those people that come that have just newly diagnosed, approach a support group, turn up, and then find out that there's other people there that have the same condition. You almost see the shoulders relax a little bit. They get this affirmation moment where they're not alone, that there's a journey to be to follow, that there's other people that have been here, that there's information that they can pick up on. So sometimes that support group is very, very important for you starting this journey properly. Now, this is a new slide, so it'll be the most difficult one, most likely. The science behind fibromyalgia. Now, I'm not a scientist, a researcher. I'm not a clinician. I know a lot about fibromyalgia because of my involvement in the charity and having the condition myself. Being an expert patient, understanding the condition, just like with any other chronic health condition, is to your benefit. So learn as much as you can. Learn from good sources. Don't go to the internet and believe everything that's there. There's enough people telling you on various news channels, media, whatever, that the internet's full of things that are false. There's a lot of people online talking about fibromyalgia that perhaps don't have a full grasp of what the condition is, or are willing to sell you something. But see the pictures on the right-hand side. In 2002, there was a study that was done. This is the first time that we got a picture of what fibromyalgia was, or what it does, a little bit more clearly. If you go to the brain, that's the third, that's pictures of the brain. It's the grid, or the grid that I'll come to in a second, but the brain that's third from the bottom, going from left to right, and you get lots of little splodges of green on it. That's pain. Well, it's actually blood going around the brain. What they do is they get control patients without fibromyalgia, patients with fibromyalgia, and then quite nicely, they attach these little devices to them that apply a certain amount of pain to the fingers. It's a nice little torture device, I think of it as, but they can measure how much pain that they apply. So the fibromyalgia patient, the control patient are getting the same amount of stimulus applied to them. And with the fibromyalgia patient, you see a lot more activity. The brain lights up like a Christmas tree. We seem to have more activity. And if you look at the grid, and you've got stimulus intensity at the bottom, and you've got pain intensity on the left, and you can see that straight line, the blue and the green on it. Now that blue above it, you've got that other little arrow pointing up. When you get a stimulus, let's say that's 2 on the axis at the bottom. When that's applied, that fibromyalgia patient is up at 12 or just below 12. It would take a stimulus of about 4 on this grid for a control or for a normal person to get that same level of pain. So it's about 2 times to 3 times the amount of stimulus applied before a normal person feels the same amount of pain as a fibromyalgia person. So up the top there, I say it's all in your head. Now, I've had doctors come to me at conferences and had those conversations elsewhere it's all in your head. And I relish those conversations because I always say, I've got a picture that proves it, and this is it. Now, there's more research that's been done, and there's an excellent article, if anybody searches for the science of fibromyalgia, and Daniel Claw, it's quite medical, but I think it's something that anybody can read. It was done in 2013, and it sums up all of this. It shows that picture as well. And I just want to make the point that between 2002 and 2013, we have learned a lot. One of the bits at the end of that article in 2013 basically says there's no longer any excuse for a doctor to dismiss fibromyalgia. They can't say it doesn't exist because the research is there. And what else do we know? Now, you might find from reading about substance P mentioned, nerve growth factor, and glutamate. We have more of these neurotransmitters. They actually come from around the body and transmit pain signals up the way, and we have more of them than a normal person. But you have the way pain travels, it also has descending pathways, and we have less of these things called serotonin. I hate this word, norepinephrine, and dopamine. You might have heard of some antidepressants that are called SSRIs and SSNRIs. The S and the N are the words from that. Now, we have less of these, and there's also a fact that everybody has naturally produced opioids within our body, and we have these receivers within our brain, and it's thought that within people with fibromyalgia, we have things in our opioid receivers that are blocked, so therefore our natural opioids and real opioids have got a harder job actually affixing themselves to those receivers. So that's sometimes in some people why some pain treatments don't work. Now, there's a term that's used, central amplification of pain or central sensitization syndrome. It's another way that we talk about how the brain works. I prefer the fact of turned up to 11. If you think about it as an amplifier, our brain is an amplifier. And a normal person probably has the volume control turned up to 4 when somebody touches them or gives them a dead arm, for example. We would be up at 11. The slightest touch, a caress from someone and a normal person is pleasant, but in somebody with fibromyalgia, it could make them jump. I remember you had someone on this morning, Jo Guest, an ex-Page Glamour model, but she was on this morning talking about fibromyalgia and had, Dr. Chris, I think his name was, and decided to make that point about the fact that you just touched someone with fibromyalgia and touched her in between the shoulder blades, and she visibly jumped off the seat. She wasn't expecting it. I talked to her afterwards. It was a complete surprise. Yeah, but it certainly made the point quite well. Now, other factors. There's a couple other things that are involved within the science of fibromyalgia. Small fiber neuropathy is sometimes mentioned. This is the idea that we might have fibers within our fingers and other areas of the body that perhaps play a part within fibromyalgia, as well as what's going on in the brain. There's some research. It used to be that you had to take a biopsy of the finger or an area of the body to see how your nerves presented to then see whether you had SFN. For a lot of people within the fibromyalgia community, they probably have some element of SFN present. That's what they think. There's research going on right now that's recruiting people to actually do a scan of the eye, not a biopsy, thankfully, to then see how SFN is presented within the eye. So it could be that in some point in the future, they could actually test for whether SFN is present to actually quantify how present it is within people with fibromyalgia and then potentially have a treatment further down the line. Autoimmune, it always comes up in the conversation with fibromyalgia. If you go online, there'll be a lot of people saying it's an autoimmune condition. It's not on the basis of what we know now. There was research done. They can't find anything at this moment in time that says it's an autoimmune condition, the way autoimmune conditions act. However, the couple of curveballs here is, in some recent research, and to do with SFN as well, that there's some inflammation markers that you get within your brain that potentially could be something to do with autoimmune, but normally in an autoimmune condition, you'd find inflammation markers within an ESR test or a CRP test. That's why our tests come back normal for them. So there's also other research. It's basically research is going on all the time. And part of the conversation, if it changes, if we think there might be an autoimmune element to it, research will find that. And then we'll find out more over time as research happens. It's never quick enough, but we get to find out what's actually happening. We don't just guess. Now, case studies, and there's 2 young people on here. Rachel, 20, remember she had difficulty at university, found it very difficult with brain fog, dealing with her studies. Rachel and Kaylee, yeah, they're not your typical person that has fibromyalgia. They're a young woman. Perhaps 10 years ago, they might not be diagnosed at the age that they are, but it shows that they're trying to conduct their life. They're trying to do things, but they still have this condition that impacts, as we all do. We're not just fibromyalgia. And if you look at Kaylee, trying to have a dream career, fibromyalgia gets in the way, it steals from you, financial problems, thinking whether the career that you've chosen is now out of reach, thinking what are you going to do next, how are you going to contribute to your family, what are you going to be like in later life. These are all things that people with fibromyalgia, because it goes through their head when they're diagnosed and all, many times afterwards. But the typical picture of who has fibromyalgia, there isn't one. There's people that are working, there's people that are running a 5K, there's people that are limited to a wheelchair, there's people that are bedbound. So it really is quite a diverse group of people that have fibromyalgia. Anybody could get it. Now, I want to just quickly about our charity, Fibromyalgia Action. We've been about since 1994. We often get asked, I mean, has awareness changed? Has it increased? Certainly in my time with 15 years involved with the charity, I know that awareness has increased. But again, it's something that's not happened quick enough. It's not where it needs to be. But that's why our mission statement is all about improving the lives of people that have this condition, increasing the awareness of the condition throughout the UK and elsewhere. We work with ENFA, a European Network of Fibromyalgia Associations, to make sure that anything that we learn here, anything we learn in America, anything we learn in Europe, we try and feed that into what's happening within the UK. But improving the awareness of this condition, improving the access to treatments for fibromyalgia, that all comes from awareness. Without the awareness, you don't get the discussions about the university want to do this bit of research, or you don't get the government thinking about how do we look at how many people have this condition and how does it impact the job market? How does it impact the amount that's contributed in taxes? How do we improve things by actually improving how we treat fibromyalgia? Awareness makes changes possible. We're a registered charity. As I said, increasing awareness of fibromyalgia, core aspect of what we do, improving the access to treatment. There have been more treatments over the time that I've been involved with the charity. The NICE guidelines take away some of the tools from the toolbox that we have, but things change all the time. And we're all about providing support for those living with the condition. It's a simple mission, but it's not easy. And how do we go about doing what we're doing? Now, we have a board of trustees, all volunteers. The charity can't exist without volunteers. Over the last couple of years, we have tried to make the charity use more staff, more paid staff, to give us consistency, to increase the amount of things that we can do. Volunteers give their time, give their skills, and it's so worthwhile. It really benefits us, but sometimes volunteers can't give for the length of time of a project or drop away because they overreach with their condition. We all do it. So having staff, we've got the equivalent of 3 full-time equivalents. It's a very small team. everything from administration to what goes on in the office, to helping with fundraising, to communications through social media and talking to everybody that gets in touch. It's all done by that team. They've got their roles, but they all help out each other. But we've also got a national helpline. We need volunteers for that. The office, not since COVID, but very soon we'll be getting our volunteers back into the office. So information packs are normally sent out by the office volunteers. Regional coordinators. So if somebody's looking for Mark's group, they would normally come through us. If they don't see any local literature, they find out, I need to find a group in this area. They come to a regional coordinator. They then get directed towards the nearest group to where they are. And we also have our medical advisory board. So when we look at our patient booklet, we look at our employment booklet, our medical booklet. Yeah, we've got to be sure that what's in that's correct, that it's sourced from good sources. And that's where our medical advisory board come in and any other subject experts to make sure that that information is right. And it's very important to us that the information we put out is correct. Now, I did say we have our national benefits helpline, but our national helpline, but we also have a benefits helpline, medical information for professionals, information for people with fibromyalgia, or information packs. I'll speak a little bit more about that in a second. We've got support groups all around the UK. Now, there's 150 before COVID. I'm sure we'll lose some because they don't want to start up, but then we're trying to start up new ones in areas, because there's always areas around the UK where a group doesn't exist because it needs volunteers to come forward to run a group. We have quite a few online support forums. Health Unlocked is totally anonymous, but we've got a Facebook group, we've got social media pages, and we do awareness raising campaigns, which sometimes that's part of fundraising. We can't exist. We don't have grants from government or any other funding grants. It's all individual giving. It's all from people that jump out a plane, that it's maybe a company that does a bake sale, or the one on the right hand side, we've actually done a presentation. That's a research place in Edinburgh, and they did events all through the year. And in the middle, we've got some RAF airmen walking from Port Stanley to Goose Green, and then all in our t-shirts, lovely photo. And then it's a 26-mile walk with full pack. So it was quite an event. And yeah, without this fundraising, we don't do what we do. Now, the campaigns that we do, we've done things about people perhaps having a dry January, or you've got the quick guide that's got information about fibromyalgia. That always creates quite a big reaction. Men have fibromyalgia. Around about November, we'll have Men's Health Month, and we'll feature something along that lines. But if you are a male within a community online, there's a lot of males that feel isolated within those communities, that they're not speaking about the same things that they're experiencing. So there are a couple of male communities as well that you can be pointed to, where males support males. And yeah, it's one of those areas that needs extra support. And then see the picture on the right hand side. I quite like this one. Become Fibro Aware. You look at a big picture of a lot of people in a crowd, and then some are coloured purple, yellow, some are diagnosed, some are undiagnosed, but you couldn't pick them out. If only we had something visible that would identify us as fibromyalgia, it would make things a lot easier. It'd make the conversations with the GPs or the rheumatologists that don't quite believe or don't want to empathise with you, it would make it so much easier. But that's the same with a lot of invisible illnesses. An information pack. And there's a couple of links there. Publications, you'll find all our publications at that link. Resources, you'll be able to order those publications. But I always say that information pack, the first inquiry pack that we send out to people, just like I was saying about Mark group and somebody turning up, that's often the first piece of information that they'll get about our condition. up to that point, they're wondering, what the hell is this condition? Fibroma what? What is it all about? Feeling perhaps a little bit relieved that it's not cancer, depending how the GPs put it across. I have heard of a GP saying you've got a terminal condition, it's fibromyalgia, instead of lifelong. Still don't quite understand, but I've heard it from more than one person. But it's a chronic condition, and then you need information to help you work through it. So that first inquiry pack is sometimes that first bit that tells you you're on a journey, that you've got a little bit of an idea where you're going, that other people have been on it, signposting to other information, learning a little bit more about what it is to have fibromyalgia, learning about how activity or how it might affect the family. I always say that this is the most important thing that FMA UK does, getting these information packs out to people that are newly diagnosed. Yeah, it helps them when they're struggling to understand what this condition is and how it's going to affect them. So it's so important. And this is the last slide. If anybody does have any questions, yeah, I'll try my best to answer them. But if anybody thinks about something afterwards and wants to get in touch, there'll be resources that people can pass those questions on. But yeah, thank you for listening to me.
Thank you, Des, for that brilliant, almost a whistle-stop tour of fibromyalgia and some of the kind of evidence and information out there for it, but also some links to resources that are there. And just two takeaways I take out of what you've said, Des. There was two key things for me. We know that it can take a long time for people to often be diagnosed with the condition. We did a bit of a survey across the country around how long it was taking people, and we weren't talking months, a year, 2 years. It was often 5 to 10 years plus. And I know my own personal journey, it took probably about 20 years actually for me to realize and get that diagnosis. I think that's one thing that I take away from what you've said. And also the fact, and just to reinforce that this isn't just a pain condition as well. You mentioned obviously fibro fog. People have a whole range of things. And I think some people have said there's up to 150 different things that often can go with it. And now that's another sort of takeaway for me. So, does anybody have any questions for us to answer? If you have, if you could raise your hand, or feel free to type them into the chat facility. And I've got to apologise once again as some of the words that are coming out in the subtitles are slightly strange.
Mark, I think there's one in the chat from Rachel.
Is there? Oh, all right. Yes, got it. Okay. Thanks for an interesting talk, Des. Could you expand a little bit more on your hopes and concerns relating to the new NICE guidelines on dealing with chronic primary pain? So, Rachel, we primed ourselves ready for this one, but I'll let Des have a go at this to begin with.
Yeah, I could actually probably talk the same length again on this, and it depends where you're coming from, what your viewpoint on it. There's actually a lot that's quite positive about those guidelines. It just so happens that for people with fibromyalgia, when they've defined what chronic primary pain is, they've then decided fibromyalgia is in there. And then they've applied it to fibromyalgia, they've applied it to a number of other conditions. But it's a relatively new definition, chronic primary pain as well. When they first came out with the guidelines, overwhelmingly, I think the number one question was, yeah, you need to actually define what this is all about to clarify it. And when they went through those guidelines, they decided to rule out things like tramadol, opioids, and gabapentin and Lyrica, or pregabalin. And the rationale that they used for ruling them out, a lot of people think is flawed. They ruled out very good trials evidence, while including trials evidence for other things. But it's very important to realize that the NICE guidance is guidance, and ultimately your consultant, your GP, is the person that looks after your care. And the rationale for approaching it Partly it's a reaction towards the way that opioids have been abused. Partly it's to do with the fact that opioids as a long-term help can often be detrimental. I mean, if it's more serious end, it can affect your breathing. So the motivation is very positive. But how they've went about it, they've took a big giant paintbrush across a number of different conditions. And effectively what they've done is, for me with chronic pain, they have taken away a really useful tool within my toolkit that might enable me potentially to go to work, to have an active day, to do exercise, to do many of the other things that they recommend. And I'm talking about me, but I'm actually talking about a lot of different people. I know our member of staff in the office that has fibromyalgia, she swears by pregabalin and will go on at length about the fact that without that, she would not be able to have the level of activity that she has. And if that's taken away, then she'll be giving up work. And I know of other people that have used their treatment regime to allow them to increase their activity levels to get to a point that then means that they can cut down on the medication that they're taking.
Yeah.
So we need more tools in our toolkit, not less. And they need to be done properly and they need to be advised. But what we also have, even though they did specify it and correct it within their actual published guide, that people shouldn't have medication stopped arbitrarily and shouldn't have working treatments taken away from them. But we know that doctors are having tramadol or other opioids stopped, pregabalin stopped, without, sometimes it's at the receptionist or when you go to fill your prescription, oh, you're no longer on that. So done without consultation, without tapering, without proper care. And that is dangerous. So there's a lot more to be done in this. But there is an approach that potentially patients will be able to take when they have their consultation with their GP, because they can perhaps cite the tramadol study or the pregabalin study that backs why it can be used. And then that GP or that doctor can use that evidence in their good judgment to find out whether it's appropriate for that individual.
Because I think you picked up on an interesting point around the toolkit there. I think that is the answer to fibromyalgia, throwing a bit of a toolkit at it. And I'm a bit more concerned about the NICE proposals in one way, in that I think it severely limits the support that doctors can give for people to be able to use a toolkit of options, because it doesn't back the use of certain things that we know work for people. So, yeah, I think moving forward, I know that we, for example, at the British Pain Society, are going to be kind of like putting a bit more pressure on to see if they can be revisited, some of those guidelines, because we felt that they really failed to engage with organisations like ours in developing the guidelines. We do have another question.
Sorry, can I just come back in that, Mark?
Of course you can, Des.
Right?
Far away.
I don't know if you read them, but for everybody to know that for the guidelines, there was 1,152 pages, I believe, of comments submitted by stakeholders, different organisations.
Yeah.
There was a lot of repetitive responses by NICE. I saw the British Pain Society, I saw Cochrane, I saw ourselves, I saw some NICE NH trusts. A lot of people were saying the same thing. Just what I've said about some trials being ruled out. A lot of people talking about, you're suggesting acupuncture, but in another guideline you've got for back pain, it says not to use it. And there doesn't seem to be good evidence there. And of course, can you get acupuncture delivered at a GP or within an NHS trust, because the provision isn't there and 5 treatments isn't going to be enough? There was a lot of commonality and criticism of the guidelines that were done at a draft stage that haven't made it through to the publication. So and I could talk a lot more about it, and there's some things that I can't talk about that I would love to talk about as well that are relevant to it as well. So apologies.
It's got to be an ongoing one, that one, and I think we'll revisit it perhaps in future sessions that we have. We do have a question now from, I think it is, sorry, I've just got to read back through the comments because there's quite a few coming through. Rachel, you've asked if you feel that it sounds like you've got a diagnosis of fibromyalgia. You're asking if there's any point in talking to rheumatology. Due to immunosuppressant medication, I take paracetamol and yocoodamol. Any advice would be great. I think just to say from the very start, we're not medical professionals, and none of us would ever want to give specific medical advice to anybody. I think reflecting on what you've said would be that it wouldn't harm for you to see rheumatology to see if they've got any kind of additional advice around any toolkit options that you've got. But I think the best place to go to get a bit of help, support, and advice generally about it would be through things like the FMA UK website. And of course, we have lots and lots of online chat forums as well, where we can talk about this thing. And I'm really sorry, but I should have said at the start that because we're not medical professionals, or indeed you're medical professional, we do have to avoid giving any medical advice. You know, have a chat with rheumatology if your GP is happy to make that referral. And I'm sorry to hear that your case is slightly more complicated, obviously because of your transplant that you've had. Right. Louise, do we have any other comments in the chat that we need to try and give a bit of an answer to? No, let's just cover.
There's one at the bottom from Holly.
Oh, Holly, I was under the understanding that if you suffer from chronic pain, opioids are not beneficial and cause other side effects and make you more sensitive to pain. So,
Yeah.
yes.
Yeah, I know where you're going with it. And again, this is one of this, I suppose you start off with, when we're talking about medications generally and how they affect people with fibromyalgia. I remember a FDA analysis of the different drugs that were out at that point for fibromyalgia. And to boil it down into the simplest form, they found out that if you had 10 people in a room and you had 10 people in a room and 3 treatments in front of you, you would find that 3 people would work or have one treatment work on you, 3 people would have another treatment work on them, and another 3 would have another treatment work on them, and then you'd have the 10th person that would sit there and nothing works for them. It's very oversimplification, but this 1 in 3 type effect, or it's only effective in 30-40% of cases. So we have these divisions within our community and the difficulty of finding what drug works with people. Perhaps in future, we will find that there are subgroups within fibromyalgia. It would certainly explain a lot if that was the case, and why it would actually increase the results of the clinical trials as well on their efficacy if they found out that this drug actually targeted this group of people. Now, how does that relate to your question? It's the fact that everybody's different. It's the fact that for some people, opioids will work. And it depends what opioid you're talking about, because there are different opioids. Tramadol is a synthetic one, and there's research with fibromyalgia that makes it slightly better than others. Some people it works on, some people it doesn't. But where your question was going is the fact that there is definite aspects to having opioids that can create rebound pain or double pain. So the actual opioid is causing the pain rather than your condition. And then you're trying to treat the pain that's coming from the opioids. Okay. I remember I was watching someone else talk about it, a professor, and they were saying the fact that there's something out there called low dose naltrexone that is used within people with fibromyalgia. There's not enough research on it, but the suggestion was being made that it actually reduces, when I was talking about opioid receptors in your brain, it reduces the clogging up that happens there, that then allows your natural opioids and anything you're taking to actually have more receptors to bind against. So potentially taking one drug to allow another drug to work. But as I said earlier, opioids can depress your breathing. Opioids can cause any number of side effects. Opioids are always for a short-term fix. They're for fixing after surgery. They're for fixing for major pain events. So long-term use, they should be the last line of resort. They shouldn't be the first, second, third, fourth. People want to kill their pain, but sometimes they might actually be causing their pain, not killing it. So that's why when they talk about reducing the amount of opioids, that's why it's so important. They have been overprescribed. They have been used in the wrong scenarios. Yeah, whether they're useful for some people with fibromyalgia, whether we have, yeah, it's very much, you have to find out what works for you. But there is definite negative aspects to having opioids and certainly using them longer term.
Yeah, thank you, Des. I think you hit a key point there, that it's about that individual person, isn't it? And again, it using that phrase again, it's that toolkit approach.
Yeah.
Will something work for you or won't it work for you? And there's often trial and error around that, actually, with fibromyalgia, and it often takes time for people to find out what works for them. And
I certainly say the CBT I referenced earlier, sometimes that's got to be the right time for you. Sometimes you need to approach cognitive behavioral therapy at the right time in your life and your journey for you then to take it on, and then it might work for you.
Can I come in there and
Yeah.
make a comment?
I mean, Louise.
So I just wanted to add as well that I think you have to be really careful, especially if you're quite newly diagnosed, in that I know for myself, I spent an awful lot of years searching for like the magic bullet or the magic pill, and spending a lot of money as well on things that were supposedly going to work. And ultimately, I don't think it doesn't exist. I think part of what you have to do, as Des has already mentioned, is find what works for you. But it's almost a full-time job managing your condition, and learning how it affects you and what you can do to make your life the best it can be with that condition. And that's going to be a whole toolbox of things, as has already been mentioned, and it's going to be different for all of us. So finding out what works for other people might give you an idea of something you hadn't thought of before. So there's all sorts of things out there, and I think you know, that as has already been mentioned, the FMA UK site's got some really good resources on there for you to check out and have a look at.
And you're writing in the comments that your rheumatology department will not accept referrals for fibromyalgia diagnosis. Oh dear. Their rationale is the GP can diagnose and the GP can give the support. The rheumatology department has no drugs or treatment that aren't available to GPs. So what are we supposed to do? And I think what this reflects is that, because obviously health services are commissioned at a local level, what we have is that variation right across the country about what different departments will do. If it's rheumatology that will get involved, if it's the pain team, if it's just the GP, often neurologists come into the picture. Every area is different. And I think we were saying earlier, what we're finding is that there's that support that's happening with specialists is kind of starting to ebb away now. And that it's something that we need to think through collectively as leaders around fibromyalgia, to see what more we can do to help improve that national picture. And Des, I noticed obviously in one of your 3 main objectives, one of them is improving access to treatments, isn't it? I think, yeah. And how's that going? Is it perhaps one of the more challenging priorities out of the 3?
It's certainly become more challenging since the NICE guidelines came out, that's for sure. But at the very first part of that, I have had so many conversations, whether I've helped out in the helpline, or whether it's in a forum, or whether it's in a one-to-one conversation, that I've tried everything. Nothing works. And I've not had a situation yet that I've not had an option that they haven't tried. Now, why is that? That's because people aren't aware of what treatments are out there. They're not aware of what you can use for fibromyalgia. I don't think it's particularly earth-shattering, the list of things that you can do with fibromyalgia. It's not some big secret. There is ways to find it out, but what the GP doesn't necessarily know because they're not trained or they're not confident. I mean, for anybody that isn't aware, that, I mean, you'd be lucky if a GP during this training perhaps gets a page on fibromyalgia. I think they might get an hour or two on chronic pain. I think that was the last reckoning I got before. So it's very, they're not the enemy. They're actually, you need to find one that works with you. They are sympathetic. The rheumatologists are sympathetic. But one of the things that I was always doing was saying, well, these are the treatments that are out there. These are the things. So that was part of our role in making people aware that there were these options that were out there, because a lot of people didn't know, or they perhaps didn't know that, okay, I took amitriptyline, a dry mouth, groggy the next morning. Did the GP not say to you to take it a little bit earlier at night and you'll feel better? No, he didn't say that. Try that. Take a couple hours earlier. It's a simple thing. You'll now find it a lot more within forums, but I've been saying it for the last 10 years whenever we get in that situation. It is advice, it is information, but it's one of the things, if you ask the right question to the GP, he will give you that same advice. The thing is, you don't know to ask or somebody doesn't ask. So it's one of those things, there's simple tips. There's ways that the application of certain medication is sometimes just as important as the knowing that the medication is there as well. And trying to have people confident to have those conversations with their GP so they can see what's there. But we're also keeping on top of what's happening elsewhere. And when something becomes available, we try and have that conversation and talk about it.
Yeah.
Something else, sorry, going back to the rheumatologists and them not necessarily helping. One of the things people should realize is rheumatologists see a lot of us, or did, or do. And we turn up and they're the specialist, they're the expert, they've got the answer to the question. No, they don't. They may have some answers, they may have some guidance, they may have some information, but they're actually just sitting looking at us just the same. Oh, in 10 minutes, I'm going to solve the 5 years of pain that you've built up in the diagnosis, or getting to this point that you're diagnosis, and then you're seeing me, the specialist. The expectation management as you go to the rheumatologist is very poor. I've spoken to them at conferences and had long conversations, and they feel just as distraught as the patient at not being able to help. And it's really important to realize these clinicians, they are trying to help, they want to help. Just because they don't know the answer, or they don't have the tools, it's not their fault. We're one of the worst people to turn up in their door. We're a jigsaw puzzle that's got pieces missing and no picture in the front of the box. I really do pity them when we turn up at their door. It's not to say they can't help us, but we need to have that conversation in a professional way, an understanding way, and listen to them and take that advice and try and actually use it at times as well. So
Yeah,
I think it's important to say.
absolutely, Des. And I think one of the things we're doing at the British Pain Society is looking at a bit of a campaign where we would like to try and get sort of specialist community pain nurses in place, so that at the primary care level, everybody's got access to somebody. You know, we have it for people with asthma, heart conditions and all the rest, but actually far more people suffer from pain. So it should be a priority. Just one final question then before we finish, because we're running slightly over. And Rachel asks another really important question around keeping yourself informed of the condition and making sure the advice and information that you get is accurate and up to date and not just anecdotal, as a lot of information is. And just to say on that, I think that's where the FMA UK website comes into play, their info pack. It's where you can come along to our website at Fibromyalgia Friends Together. There's a lot on, as Des said, on kind of support groups. And yes, those support groups and Facebook groups, there is a bit of anecdotal conversations there, that there is a bit of advice that perhaps shouldn't be given, but that's where you'll get the real benefit from. And you need to weigh up what you're being told, I feel, yourself, to see, again, what works for you. But really do use the kind of FMA UK resources. And of course, the NHS has a page on it too. And indeed, NICE has its guidelines on there for fibromyalgia. primary chronic pain too. Des, was there any other information resources that you could think of we could?
There's going to be fibromyalgia diagnostic guidelines that are going to be coming out quite soon. We've consulted on them. They're not, the draft has just been finalized. So they're not out yet, but they will be out quite soon. But I would like to share that one of the things that it says for clinicians to approach a fibromyalgia patient with is to be very aware that they're not saying anything like it's all in your head, or this pain isn't real. And I found it had about 5 or 6 statements around about that were really positive in enforcing the fact that how you actually talk to someone with fibromyalgia or chronic pain is very important. So the guidelines are quite positive, and it would be good to have a level playing field across the UK, that people were treated the same. NHS Choices website is excellent. One of the things I would say is that when you're weighing up information, when you're talking to somebody else that's not connected to an organization that researches its information, when it's just an individual, then put what weight into it that you feel is relevant. But when you're looking for organizations, when you're looking for groups, when you're looking for companies, and some companies look like charities but are companies, look for things like the information standard, look for something like the PIF tick, or look for the fact that it's a regulated organization, like a registered charity like ourselves. Our reputation is on the line with every booklet, every leaflet we put out. I'm very keen to make sure that the information we put out is accurate, is sourced. It's accurate at the time it's printed, because things get updated. I don't mind things being corrected. If there's something wrong in our site, tell me. I'll be happy to go and correct it. So weigh up the information and where you get it from as against the suggestions. And make sure that when you're making a life-changing decision or something that could change your life, make sure that you're weighing up that information with the right amount of consideration. Don't just take it and act on it. Make sure it's correct.
It's like what we have to do with newspapers. We have to believe them or question them. And more often than the time, I think it's question them, but there we go. I'm going to bring it to a close. I would just like to say thank you to Des for coming along tonight. I think that's been a really informative and interesting conversation. And I think also thank you to everybody for your fantastic questions, really kind of insightful to what you're going through, but also what some of your concerns are. And it gives us something to go away and reflect on. I just want to finish by saying that the Footstep Festival is run by volunteers, and we can only keep it going with donations. So please, if you are able to make a donation, whatever size it might be, we'd be really, really grateful for that. Thank you very much to everybody that have donated now over £1,700 to the cause. We're really, really grateful for that. It's fantastic, and it will help us keep going. But I just wanted to say thank you to everybody for your time tonight. And please hope to see you again at one of our other events, don't we, Louise, throughout the festival. So good night, everyone. Thank you.